for your real effort putting this meeting online. I know it's a lot of hassles and efforts. And to Bahrain Pediatric Summits, I would like to thank you, and a special thanks to Dr. Mahatwa. Dr. Abdullah, in fact, when I started to go through the agenda of the meeting and I found this coffee break in between, I was wondering if these days coming back or not, because we're in Corona time, we can't sit together and share a cup of coffee and have the chat with our colleagues, whether the speakers or the audience. So I wish 21 will be better than this year's, I hope so. Well, as you can see, the title of my presentation is a spinal dysraphism, and probably few of us are not that familiar with this title. Just to simplify it, yes, the word dysraphism itself means incomplete fusion. So if we have two ends of an object that didn't get fused together, or we have two objects that didn't fuse, this is what we call it dysraphism. And as we know all that ectoderm, as it forms the skin, it forms also the spinal cord. However, the mesoderm forms the whatever surrounding the spinal cord, like the vertebrae, the paravertebral muscle, and the soft tissue, including the subcutaneous tissue. So here, when we describe it, it describes the incomplete fusion of the ectoderm during formation of a spinal cord, as well as formation of the mesoderm for the vertebrae and soft tissue around, as I just mentioned. So when this happened exactly, incomplete closure, in fact, of the neural tube, it happened at the start of the 4th week of embryonic development till reach the end of the 7th week. So this process, all it happened very early in the pregnancy. And usually we don't see one malformation. In fact, we see combined malformation. Like you see meningomyelocele, and you can see spina bifida at the same time. You see tethered cord, you see skin manifestation. So usually when it comes like a combined malformation rather than be a solitary or a single one. So if we look at these slides, actually, it showed how this fusion started. It usually starts, or it did start actually in the middle zone, and it goes cranial and caudal until it completed by the end, as I said, of the 7th week. So at any stage, if there was a failure of fusion, whether cranially or caudally, this will gonna end by one of these malformations that we are talking about, the spinal dysraphism. And why we said the spinal dysraphism for this presentation, because there is other entity which is cranial dysraphism, like what we have in occipital encephalocele. And as I said, when the cranial part of the fusion, when it happened to fail to get fused properly, we might have this anomaly starting by occipital encephalocele, and it might end even by anencephaly, which is an extreme malformation, and it ends by death. So spina bifida, yes, this was the term that we were using before, which literally means open spine or spine in two parts. But what I want to say that better nowadays use the spinal dysraphism terminology rather than using the spina bifida, because spina bifida, it gives a little bit impression that we are talking about the vertebrae rather than we are talking about the whole things, including the spinal cord, of course. So spinal dysraphism, by definition, it's some congenital anomalies resulting in defective neural arch through which meninges and or neural elements are herniated. So the secret word is a herniation of the meninges and or the spinal cord outside, to be pouch outside the defect of the spine. Well, about the classification of spinal dysraphism, either we have open spinal dysraphism, which is OSD, or closed spinal dysraphism, which is CSD. And of course, as I just mentioned about the spina bifida, also spina bifida before we named it either spina bifida occulta, where there is no skin defect, the skin is intact, or spina bifida aperta, where we find the lesion going to outside, and a special entity where we call it spina bifida cystica, or the lesion to outside with a closed cyst around. So what are the examples of open spinal dysraphism to start with? Myelomeningocele. Meningocele are the commonest and the most important entity for most of us. As a neurosurgeon, we can face it in our career, although, of course, it is a very rare anomaly all in all. Then closed spinal dysraphism, as I said, as I just mentioned, you don't find one malformation, you don't find one symptoms or one associated finding. No, we might find lipoma, whether it is intradural or close to the filum terminale. We might find it, of course, subcutaneous, going inside, dipping in the spinal canal. Tethered cord, which is a special entity, and I would include this in my case presentation by the end of this. Tethered cord is very important items because it pull upon the spinal cord and putting it at the lower level, which definitely will affect its neurological function. And as I just mentioned, complex spinal dysraphism, we have it in many forms. And as I said, not a single entity. It might be meningomyelocele, tethered cord, enteric fistula, split cord malformation, if you remember it, where we have what's called diastematomyelia, and we have a bony spurs coming from the ventral aspect, splitting partially the spinal cord. And in these cases, or in this surgery, we need to drill the bony spurs and to put both part of the spinal cord together and sew the dura. And also hemivertebra is one of these examples. And talking about diastematomyelia, you have to talk about the diplomalia also, where we have two separate spinal cord. So let us take a look for these photos that might show some anatomical points. We all know that the spinal cord starts here. If you, I hope this is showing at your side well. The spinal cord starts at the lower end of the brainstem, and it goes all through down till the level of L1, L2 vertebrae. So if we look at this diagram, it is here somewhere with the it ends here somewhere between L1 and L2 vertebrae. But if we look at in where we have the tethered cord, or what we call it low-placed conus medullaris, we can appreciate that the lower end of the spinal cord, instead of being goes to the normal place, which is L1, 2, it goes a little bit more caudally below L5 vertebrae. As I said, it's an abnormally low conus medullaris position, and you can see here the difference between the normal spinal cord and when we have an example of occult spinal dysraphism. You can appreciate the presence of fat here, and instead of the cord or the conus medullaris being at L1, 2, it goes all through down, probably to the L5 or even below that. And this is what presents the tethered cord. Well, an example for some of these malformation, we have spina bifida occulta, where we have a defect in the lamina. You don't see the spinous process. You don't see both parts of the lamina because it's not fused, and probably it is deficient also. And here meningocele, where there is a pouch of the meninges going outside. And on the other hand, with this myelomeningocele, we can see the pouch of the meninges with the neural element herniated inside. So how it looks? It looks actually somewhere like it looks actually like that. When we see it, we will see definitely an abnormal skin, and even part of this skin looks very thin. We call it zona epitheliosa, and it's very critical when we have the baby born and they have this swelling of myelomeningocele. We want to make everything, we want to keep everything safe, because this membrane, which is the cell membrane, in fact, is liable to get ruptured with the CSF going to outside, and it jeopardizes the neural element, whether the cord or the nerve roots, to get harmed. And also at the same time, it will be one way to pass the infection to the CSF and subsequently to the brain. So we want to keep it safe. We always keep the swelling with pieces of gauze over it. We keep it wetted all the time, And we might put non-irritant antiseptic topical agent just to protect against the infection until we do the surgery. And surgeries in these cases actually is so emergency and so urgent. Probably we do it in the same day or the day after, till we get prepared for repair of this myelomeningocele. And by the way, we have to always remember that once we have a malformation, we have to check for another malformation. We have to check about the brain. We might have a hydrocephalus, or it might be a syndromic with like a Kyrie malformation. And not only that, but also it might be there is an associated malformation in other area rather than the nervous system. So we always keep an eye on other malformation, and we appreciate what is there in the brain. And usually you should get a CT brain to address the situation, whether there is any anomalies or not. Well, about the surgery, I know that it is written in the literatures, and there are in many centers, or probably a few centers, they're doing it while the baby is intrauterine. We call it prenatal repair of myelomeningocele. It's a little bit more fancy, but what we do usually, we do it after birth, whether in the first day or the second day, or even if the patient was tolerating or the baby was tolerating, this was within few months, we can later on operate upon. I just want to show you where we are here, where this is representing the myelomeningocele, and this would represent the incision. And when we go for the surgical incision to repair this anomaly, we should be somewhere between the black coat, which is the primitive neural element, and the abnormal skin initially, just not to injure the neural tissue and to get enough space to dissect from within all the tissue toward the black coat, very carefully, of course, and of course using the microscope. Well, let us look at this one, just give us an idea about what's going on in this anomaly, and especially in the cross section. What we can see here, we look at the central canal, and we can see the placode, which represent the primitive neurogenic tissue. And it looks like the spinal cord was ruled out openly. And what we have to do, we have to rule it in again and put it inside, making everything is inside as it should be. So when we look at this diagram, we can see the placode here and this very thin skin, which we call it zona epitheliosa, and then the edge of the skin, which is also a little bit abnormal. And we will realize that the dura all around is attached to the soft tissue as well as the zona epitheliosa. And we can see and appreciate the roots, which is coming out from the ventral aspect of the placode, usually the dorsal root first and then the ventral, whether it is sensory and motor, starting by the sensory outside to the motor inside. So what we do here is going to the junctional zone, and we start the incision and then the dissection from within to keep the integral placode with anything of the neural tissue. We have to be very careful because I would say this is one of the very, I would say it's an uncommon procedure, but it's a very critical procedure. Although it looks in ideal, it's very simple that you will gonna open the sac and you reduce everything and put it down. But watch it, it's very critical because you might turn the patient paraplegic. You might turn him with more deterioration if we injured any of these neural tissue here. And when it looks close to the end, it will be like that, the placode. We try to make a good cover of whatever to the dura. Sometimes we take an aponeurosis and repair the dura with it if it is defective, or we take like an artificial dura to make sure that we are sealing the dura to prevent the CSF leak. This is one of the cases. You can see how the skin is very, very thin here in this area. This is the zona epitheliosa, in fact. And when we do our incision, we go a little bit, of course, away from this margin. We start somewhere here and going step by step inside just to go toward the placode, making sure that we don't have any jeopardizing or injury to the neural elements. Well, as I said, tethered cord is a very important entity. It's one of these malformation, And usually it doesn't come alone, it comes with other malformation. Like here, you can see there is fat here somewhere close to the low-seated conus medullaris. And in these slides, you can see the fistula, or what we call it, the sinus. And usually this is represented on the skin by dimple. And if we look at this picture, I would like to say it's very, very beautiful one that showing everything is clear. But I can assure you, usually we don't see the things so clean and so neat like that. We always struggle with these cases, especially if it was a revision cases or it's a recurrent case. And I have to tell you, we would appreciate if we fix or revise or make a repair for the myelomeningocele, for instance, at early age. We have to appreciate that this baby is growing up, so we should expect at some time that he might show a kind of deterioration and he might need a revision. So for those neurosurgeon will go again and open the same case, definitely they will have more difficulty rather than the difficulty they will gonna face in a fresh case. And of course, most of the surgeons know that. So what are the findings, the associated finding for the tethered cord? Well, we might have the cutaneous finding. If you look at these slides, you can see here the port wine pigmentation. You can see a dimple. Sometimes a sinus goes to inside. We might have a gait difficulty because, as I said, it will affect the ventral and the dorsal roots as well as part of the spinal cord. So definitely we might have a gait difficulty. We might have weakness of the lower limbs. Sometimes the deformity, like a short limb or ankle deformity, we can look at this here. And probably like what we're gonna see in the case that I'm gonna present at the end, you have like a clubfoot deformity, you might have inward deviation, you might have hammering of the toes. So all this kind of deformity might be associated with the myelomeningocele or whatever the deformity of or the malformation of spinal dysraphism. We shouldn't forget about the sphincters. We usually, or in severe cases, have double sphincters. We have bladder incontinence. So when we go to our case, she actually is a lovely 3 years old girl. She's so cute. She's from Seychelles. And I met her like 7 years or 6 years ago. At that time, they came, the whole family, and the history was about that. She was born with a lumbosacral myelomeningocele that was repaired, operated upon a day after birth. And mostly this was an urgent case because probably there was that finding, which is, I just talked about it, like the thin skin and the exposed cord. So they definitely, the first surgeon wanted to keep everything and he did a great job. So also, as I said, we should look at the brain. And when we had the CT brain, it showed dilated ventricles, but apparently it was compensated very well because the girl was absolutely mentally normal and she didn't show any cranial related manifestation. And I will gonna show you these slides after a while. So what was the main presentation? The main presentation actually was double sphincteric incontinence. She was having urinary incontinence and fecal incontinence. And on examination, of course, there was a patulous anus. And when we look at her while she was walking, when she came at that time, she was 3 years old. There was definitely a waddling gait. And with probably this was due to the proximal weakness rather than to the distal deformity. And there was, of course, mild foot deformity, as I just mentioned, hammer toes, and inversion of the foot. So when we look at the MRI, as I said, this is at the age of 3 years after, and of course, the repair had happened after birth. And we can appreciate here that the conus medullaris, or the lower end of the spinal cord, it goes here somewhere at the level of L5 vertebra. But in fact, intraoperatively, it was even at a lower level below that. It was more caudally. And when we look at this cross section at this area, the lower lumbar area, from the cranial to the caudal direction, we can appreciate that the cord itself started to migrate or move step by step posteriorly. It goes toward the dura. And when we look at the last slides here, which is the most caudal, you can appreciate that the cord attached to the surface, the inner surface of the dura, or whatever left from the dura, as I said, because this was repaired before. And this is a very important and crucial point, because when we're gonna open, we know that as an all surgeon and all the surgeons, they like to open in the midline. But in these cases, you have to avoid the midline. Of course, you can open in the skin and soft tissue, but when you reach the dura, you have to avoid the midline. Otherwise, we might injure the cord, which is dorsally seated, and not only that, but attach it to the dura. And of course, we don't know what is there inside with it from the nerve roots. So in this case particularly, I prefer to go from the left side. And I usually do an X-ray to see the bone, and sometimes you can go for CT scan just to see how the bone there, what kind of bone defect you have. Especially this was operated upon earlier. And I would recommend the same for the cases revision after, and where there is a revision after revision. We have to know the edge of the bone that we're gonna go through it. So here you can see it very clearly in the anteroposterior projection, that the cord didn't end here, but it goes all through down. And as I mentioned, intraoperatively, it was even below that level. And let me tell you that in this case, the patient are lucky when they have this wide spinal canal. And it might remind you by the cases of spinal deformity like scoliosis and kyphosis. Always for the spine surgeon and neurosurgeon, when they deal with these cases, they might recognize that the spinal canal is so capacious and wide, and probably this was for the enough compensation for whatever happening for these curves at the scoliotic or kyphotic curve. Okay, this is another X-ray, sorry, another MRI myelogram. It just showed not only the low-seated conus, but I want to point, I want to pay your attention here to the bladder. As I said, there is an sphincteric incontinence, there is a bladder incontinence, and this means that we have an atonic bladder, and of course you can see it here very clearly standing up in the pelvis. As I said, we have to go for the brain just to check what is going on there. It might be a syndromic, it might be with Xray malformation, it might be with hydrocephalus. And for these girls, for this girl particularly, there was a hydrocephalus. But as I mentioned, it was properly compensated. The girl was absolutely perfect cranial-wise. Not only that, the hydrocephalus there, but also if you focus more, you might find a kind of agenesis of the corpus callosum. That's why I intentionally mentioned that she is mentally perfect, and as well as all other cranial symptoms or other cranial functions. So, as I said to you, I always like to make an X-ray. This is a lateral view just to show how the vertebrae and whether there is a bone defect or not, like in spina bifida. And in this one, I just put a metal marker. In fact, it's an unfolded paper clip. I put it exactly over the old scar, just to know where I am at this level when I will open, because usually we open the same scar, especially in children and babies and girls. We want to save them for the cosmetic appearance. So we go through the incision. So I like to know where I would be when I go through this existing surgical wound. So this showed where at the level, we are even at the level just below the sacrum. Just this is S1 vertebrae, and we are here. And also it showed you the extent of the bone defect. If you look at this, margin, here is the bone edge. And fortunately enough, those babies have a very wide interpedicular distance, and we should look at the edge of the bone where we will go through. And lucky enough, when I did operate on this girl, there was a cartilaginous part of the vertebrae. Of course, it is not yet completely developed, and that's why we didn't see it in the X-ray. But it was good for me intraoperatively to go through it because it gives a little bit good plane of dissection to go underneath. Although it is again one of the very difficult cases as a neurosurgeon you might face. I'm putting the arrow here again just to show that there is a loaded column, because I just mentioned about the double sphincter. So like there is a fecal incontinence, there is a loaded column because there is a kind of dilatation of the bowel. Now, what would we do? What we're gonna do? It's in fact an exploration and detethering, which means release of the cord. This is the main goal, or this is a surgery actually. We want to go inside very carefully just to explore and to identify the neural, all the neural tissue actually, not only the cord, and try to detether this to release it and put everything as it should be back inside again with the maximum awareness about not to injure any of these nerves, otherwise we will have a complication that will end by, and for instance, easily paraplegia, and we don't like to get this. So what is the aim of the surgery? Well, it's to stop further progression. You have to sit down with the family. We have to talk to them thoroughly about what is there and what we have to do. It's the main aim of this surgery is to stop further progression. And trust me, if you succeed in this, this will be a big achievement. But also, if we are able to improve the neurological function as possible as we can, this will help later on in the rehabilitation. This is the intraoperative pictures where we can see the child in the prone position. And if you look at this, this is actually a colostomy bag. And why we are applying this to the rectal area, because we want to seal this area away from the surgical wound, which is very close. And this is probably the best way to keep this area away from that. As I said, there is a kind of fecal incontinence, so we didn't like our surgical field to get contaminated. And here we look at the old scar. It was transverse, which most of the surgeons try to do to be able to repair the skin or to prepare to suture the skin back again, because usually we have a difficulty in this. And you can appreciate that the wound is about 13 centimeter. And usually me and the other surgeon, of course, prefer to get the keloid excision out for a little bit more cosmetic appearance. So what we do, we started after the dissection, after the incision in the skin and subcutaneous tissue, we try to go more and more deeper toward the dural sac. And we sometimes face another problem here, which is the muscle itself. This girl was operated upon very early, and we always face the problem that we need to get a good size of the muscle for the late closure at the end of the surgery, because you want to protect the spinal cord and the dura underneath. So in cases like that, after the section of the subcutaneous tissue, we try to preserve whatever there. And in fact, it was difficult in this girl. It's hardly, I was able to get a sheath of the muscle here. And thank God, by the end of the surgery, I was able to close it to protect the core. But you can see the dissection going up caudally, cranially, and down caudally until we have good plane and we were able to explore the dura, or what I have to say, what is left from the dura from the first surgery. And the next step, of course, after good exploration or good identification of the dura, we have to put the microscope in. And I would say without the microscope, I don't think we can do a good job in this kind of surgery, because you want, as I said, to preserve each and every neural tissue you will face inside, like the spinal cord, whether the spinal cord or the neural tissue in form of the coracoid. So what we can see here after opening the dura, I hope this is appear very well at your side. Do you see it well? I wish so. So we can see here the dural edge. This is the dural inner surface with the cord adhesions here, and what we call it the placode or part of the placode. And as I said, we have to be very cautious detecting this all through from the inner surface of the dura. Here again, you can see the thickened placode. I am trying to move the arrow to this, and I hope you can see it. It's here somewhere. It's actually like, I would say it's a mess of neural tissue. It's like a tuft of everything. So you have to be very patient, take your time, and try to do it at ease as much as you can. We can see here the release of the spinal cord itself from the inner surface of the dura. And I was able to create a good edge for the dura here for eventually repair of the dura to get sealed. Once you freed all the adhesions away from the inner surface of the dura, you can say nearly you finished your job. I'm about to finish. Dr. Abdullah is earning. Once we finish this, you know that you are nearly finished the whole important job. So post-operatively, you can see I just did this to show that the additional bony work we had to explore better and to go through all the neural tissue, just for the safety of the patient and for the integrity of this neural element. Otherwise, it will end up by a disaster, or as I said, the least you can get is sometimes paraplegia. So this is an actual photo taken by the mother friends in the first post-operative day. And after 2 weeks, after she came and the suture were removed, thanks God she was able to walk freely. And the waddling gait at that time improved significantly, I would say significantly, even the deformity. But you would be lucky enough as a neurosurgeon to see the patient in a follow-up visit after few years, because usually we see the patient in the first few visits, and then after that you don't know anything about him. But fortunately enough, I saw her again 4 years later. This was at the age of her age was of 7 years, and she came from Seychelles, and she got me a kind of present, specific present from there. And I was so happy that I saw her improving and progressing. And I would say her gait was absolutely back to normal. The motor function was good. There is no more waddling gait. And I took for her a very short clip showing her while she's going down the stairs. You can see it here. Now from the look at the So definitely, I was happy, as well as the family also was happy with this. And I realized something here. Our test and dressing is actually don't change. The mother chose for this girl while she was at the age of 3 years, the same color, the pink and the gray. And again, after 4 years, she came to me and she have the same test. They are amazing family, actually. They are so lovely. And again, as I said, I was lucky enough to have her after another 2 years. She grew up. She has now she aged 9 years. And lucky enough, there was no more motor or any deformity, and she was doing great. Apart from the same problem, which is a sphincter, it improved to some extent, to little extent. And in this aspect, actually, we start to communicate with our colleagues. As I said, usually in cases of neurosurgery, as I usually say, it's a multidisciplinary in some circumstances. So we needed the help of other pediatric surgeons as well as the urologists to go and do to help us for this the bladder. But the end result was absolutely marvelous, and everybody was happy about it. Thank you very much. Thank you, Dr. Abdullah.